some people might just remember, like me, a couple of days at the end when they were getting weaned off. But the family will remember absolutely everything, because they're very much aware, and it's very much the worst time in their life as well.
Sure.
So.
Some departments, like here, they have diaries for the family to write.
So the ICU Diary program wasn't rolled out during my time. It was rolled out shortly after. It's like everything. If it's done well, it's great. So if everybody's writing in it, and everybody's kind of, putting in what they put in, then they're great, because it helps the patient fill the gaps, and helps to explain. So I worked out for myself, like the scars correlated to where I was being cut, but the diary would help maybe patch other things in, and that can help you bring kind of understanding to what happened and why you were having things happen in your head. Because to me, ICU delirium seems to be response to the stimuli of ICU. So you're unaware of what's going on, but my brain's aware of things are happening to me, and it's going, well, something's been put in your wrist. You must be getting cut. Something's been put in your... So you're piercing my skin. You are cutting me. So my brain is trying to understand that signal, and the only way it understands the signal is someone's trying to cut you open. And I was being drowned, which to me probably corresponded with the ARDS filling up my lungs. So most of what happened to me, I can now rationally understand as these things, but it would have been easier if there was a bit of paper that said this was what was going on here, these things were happening.
Sure. That's really interesting to hear that, actually. We're just starting to roll it out here. So it'd be powerful for our staff to know your experiences, and that actually it really does help. That's really good to know. I was wondering about in the period where you were going home or getting ready to leave ICU. I can imagine it's a really frightening time as well. Do you have advice for patients who are about to...
So going that? From ICU, stepping down?
Sure.
I don't have very many clear memories of it, so I was only kind of aware a couple of days in ICU, so most of my time I was induced. But it's terrifying, because you're aware you've went from this location where there is a nurse pretty much sitting at the end of your bed all the time with all this support systems around you, to go into a ward where you're maybe one of two, one of three, one of four. That's quite a big shock to your system. And that no longer, when you need something, is there going to be person there, which can be quite frustrating. And that if you're maybe you want to sit up in the chair, or you want to try and sit up at the edge of the bed or whatever, that would have been a much easier thing perhaps in ICU, because the people there would always be a person there.
Sure.
But I suppose it depends on where you are in terms of kind of your recovery. So I was still quite early, so it was a bit jarring and a bit scary being maybe if you're a bit more aware, you might think of it as, well, you know, ICU to HDU is a step to out the door.
Yeah.
Because that's certainly how I looked at stepping down from HDU to the ward was, well, this is me nearly there. Obviously that didn't pan out ideally, having caught the flu, and that kind of set me back probably 6 weeks, even though I was, well, it hit me hard because I was weak anyway, and flu is not great for MD anytime, but yeah, so stepping down scary, whether it's ICU to HDU, HDU to the ward, or ICU to the ward, which I have heard has happened, which that would be terrifying, because you're going from 1 to 1 to 1 to 8 maybe, where you're going from lots of support to not a lot. So it's just kind of understanding that that's scary, and that might rattle things loose, that things might become more apparent when the kind of, not comfort, but like the safety of the kind of ICU bubble is burst, and that you know, ICU is highly staffed. There's people, there's lots of things. If anything goes wrong, people there, response is quick. Where you maybe feel a little less supported once you get down. You kind of hope that when you get to there, you're better and you need less support, but it doesn't always feel that way when it's happening.
It sounds like you had so many nurses that have played a hugely important role in your life. Do you have anything to say to the nursing community?
Well, I have. So the nurses are the people who kind of deal with you most of the time. So when you're on a ward, you see your nurse maybe 8, 10, 12 times a day, where you'd see a doctor once a day. So when things are going wrong or bad, it's usually the nurses that can see it, or the nurses that you speak to. So it's just kind of like everyone understanding that these are the people that are in contact with the patient the most. So if they think something's wrong, probably is. You know, like particularly with delirium. So if a doctor's seeing you once a day, are they going to really be able to tell if there's a change in mood or a change in behaviour or a change in consciousness? Because they see you in the morning and you're tired. Does that mean you're drowsy?
Sure.
No, it probably means that you had just got into a good sleep and they've come in and woke you up. So like the nursing staff play a huge role, particularly to me in delirium, because they're the people that see you the most. So they're the people that will see that change, and obviously seeing it quickly is important, because the quicker you can see it, the quicker you can reverse it. Because yet again, my belief is that the longer the delirium is, the worse it is afterwards psychologically. So yeah, it's a big deal, and I think they play the biggest part in that puzzle.
Are there any other staff members that you remember who facilitated your journey?
So there were a lot of. There was a couple of junior doctors, Dr. French and Dr. Brain, who I think they were registrars, and Dr. Miko, who was I think he was a trainee at that point. He's now a consultant. They came up to see me NHCU, usually during the middle of the night. They would come in, and I don't sleep particularly well in hospital. I sleep in like 2-hour bursts, so they would come in and then they would speak to me and ask me how I was doing and things like that. So that was quite, that was good in that it was faces from ICU who would come in and saying, you know, how well you're doing, because you don't see how much you're recovering, because you're recovering a small bit every day. So you're looking in comparison to yesterday, and there's not an awful lot of change from yesterday. But when someone comes in and says, oh, 2 weeks ago you weren't able to walk, and you're not able to walk 20 metres, it kind of brings home that. One of the deputy charge nurses as well came to see me from departing ICU to leaving. So that was kind of important as well. Just that link from the ICU all the way down helps, because they can kind of reinforce the amount of improvement that's happening, and just kind of be reassuring, because they're from the place that saved your life in most cases. I think
that's nice, that continuity.
Yeah.
They came to another area to come and see how you were doing and reassure you.
Yeah, so I think they were all anesthesiologists, so they were they kind of wander the hospital, because the patients aren't necessarily in one. So yeah.
Can you tell us a bit more about the Inspire services that you were chatting about?
Yeah, so Inspire, I can't remember the acronym because it's a strange one. So it's Intensive Care Syndrome Program for something returning to employment. It was funded from the Scottish Government, so it was about getting people back into work. But it was really good to me. I can't necessarily remember exactly what was done. So in my version of the clinic, so the version of the clinic I had and the version that I helped out as a peer volunteer were very different. So the one I had, we did physio every session, and then there was meetings with the ICU consultant and nurse who explained what had happened to you, kind of just, explaining to you, you were in ICU, this was why these things were done. And then you had a meeting with a psychologist who went through the questionnaire for anxiety and depression, which she'd done at the assessment day before. And then you did, I think it was the second last week, to see if there was any change. And then you had a peer volunteer spoke about their experience and what happened. And those are the things that really stuck in my head. Psychology was the big thing to me. I think you can't have a post-ICU service without psychology. I think it's such a big part of the puzzle, and that a lot of people have psychological issues after ICU. So it would be like not having physio. To me, that would be, you would be missing a big piece of the puzzle. But most of it was because it was a group of people. We were either ICU survivors or we were family of. So the survivors, we kind of understood. We didn't, we kind of talked about what had happened, but we all understood what had happened to everybody else, because we were all in the same boat, really. So that was good, and the kind of the support of it, and that what happened to me wasn't that strange, even though it seems that strange. that was a big deal as well, because I don't think I really spoke about it, because it is a bit strange. You know, like when I woke up, I was like, yeah, okay, that wasn't real, I get that, but you know, I still had memories of it. So you kind of don't talk about it, because if you don't talk about it, then you know, it didn't happen, didn't matter.
Yeah.
But it kind of catches up on you. Like when I went to the assessment for the clinic and just was hit with the panic attack. Yeah, it was. The clinic was great. I think it's great, and you know, I'm glad that it seems to be getting rolled out now everywhere.
Is it? Yeah.
Yeah, that's
And you're a peer
according to the
volunteer
government. According to the government, I was the peer volunteer, but you kind of do it for a year, because you kind of burn out, and it's quite hard on you, you know. And it's always nice to have new people, new ideas when you're doing it. So bringing different people. But yeah, that's good, and that kind of got me kick-started on doing everything else. So that was where it started.
What else did you do?
From that, I spoke at the Delirium Training Day conference at Ayrshire and Arran with Dr. Masharu, who's moved to Australia now, left us. And then before that, I'd spoke at ICU Steps Edinburgh.
Lovely.
And just earlier on this year, I spoke at the European Delirium Association's Training Day in the Royal College of Physicians in Edinburgh. That was scary, but not as scary as I thought it was going to be. I thought it would be quite nerve-wracking, but once I started, that was fit, and then I got to enjoy the conference, listening to everybody else. Yeah.
Okay. A lot of people are interested in hearing what you have to say, and you've become a teacher almost, haven't you?
Well, I don't know about that. I just give my opinion. But the sign guideline for delirium coming out was the big changer for delirium, and that it now says you have to do this, which I think, and it gives a kind of structure to how people do things. So beforehand, different tools were used, people used different methods of things. Well, now you're told this is what's best, this is what the research says works, so this is what we use now. So it should mean everyone, regardless of whether they're in the Queen Elizabeth or whether they're in Ayr Hospital or in Aberdeen or in Edinburgh Royal, they should all receive the same care. If they've got delirium, they should get the same steps to try and prevent and reduce or reverse the delirium. So that's a big deal to me, because it's always best if everyone is doing the same thing, because you should get the same result. So that was a big deal, and that kind of started the delirium awareness ball rolling. So.
And how do you see the future of ICU delirium care improving in the NHS?
I think I'm maybe a little more controversial than other people. I don't think ICU can eliminate delirium. I don't think it's possible, just because of the drugs that have to be used and the things that have to happen. But I think we can reduce it, and I think we can get it so that it's not so much a part of the ICU process and recovery. So things like ensuring proper sleep patterns, light darkness, for melatonin things, getting actual sunlight. So when possible, getting patients outside in the actual sunlight, that's been proven to be quite useful.
Right.
Getting people moving as soon as it's safe. Getting family and items from home to kind of help to reorientate is a big deal. These things, there's nothing in here that's hard, really, but they make a big difference.
Right.
From from what has been shown in America and Spain and other places that are kind of more, because taking people outside in Spain is a lot easier than in Glasgow.
Needs a few umbrellas to take them.
But these things seem important, particularly sleep. Sleep seems to be, I know Dr. Khan, I can't remember what it is, Indiana, University of Indiana, I think. He says the average sleep time in the ICU is like 37 minutes.
Oh, really?
Total.
Goodness.
So that wouldn't be helpful anywhere.
Sure.
So why do we expect that ICU patients, if you get more sleep, you tend to be in a better situation, you have more energy and things like that. So it's a big deal. And it has a big part in the puzzle. But like everything, it's not one thing's going to sort it. It's improving all little things. But so it's delirium's a big part of the ICU puzzle to me. That's what I think had the biggest impact on me, because the physical stuff, the muscle loss and things like that, I'm relatively young. I can bounce back from that pretty quickly, even with the other health issues. But the psychological things are, you can't just walk them off.
Sure.